Hello all. So today I just wanted to recapitulate one topic or one point in the last class. We were talking about this thing. I wanted you to clearly explain this to you because in some patients with COPD, patients who retain carbon dioxide, but means there is already chronic obstructive pulmonary disease. These patients, the respiratory centers will be stimulated by the presence of carbon dioxide. Normally, respiratory centers in the lung in that region are stimulated by the oxygen levels, right? If the oxygen levels are low, the breathing rate will be increased, respiration rate will be increased, so that their intake will be more. But in these patients, the carbon dioxide will stimulate the respiratory centers. So in those cases, if we give a supplemental oxygen in these patients, what will happen is the respiratory centers kind of will not respond because carbon dioxide is stimulating the respiratory centers. Giving a supplemental oxygen will be very difficult or very critical. If we give that, then respiratory centers will not be stimulated and they'll have breathlessness. That is why, if considering oxygen supplementation, we have to consult the patient COPD action plan or alert card or bracelet. We have to observe what is his action plan. That is why it is very important to note this point. So going forward, next coming to obstructive sleep apnea, we discussed about that different causes of obstructive sleep apnea, how sleep studies will be done. As a dentist, what can we do with the appliances, jaw advancing appliances, but with the consultation of the sleep medicine specialist or the physicians, we have to take their opinion and advice. It is a multidisciplinary treatment modality. So in those patients, what are the dental considerations? Dentists have an important role in the multidisciplinary management of obstructive sleep apnea. Uh, um, for advice on the dentist role in identifying risk factors, that is again the role of dentistry is there in separately in obstructive sleep apnea. Patients with obstructive sleep apnea are at increased risk of respiratory arrest from benzodiazepines because sedation also it depresses the ventilation, right? Ventilatory depression will be there in benzodiazepine. So that is why they have an increased risk of respiratory arrest from the benzodiazepines. Nitrous oxide is recommended for minimal sedation in patients with obstructive sleep apnea because it is safer and shorter acting than oral benzodiazepines. So we should never give oral benzodiazepines for the patients with who are having obstructive sleep apnea because they are at the increased risk of respiratory arrest from the benzodiazepines. So if at all we have to give, that should be minimal sedation with nitrous oxide. Dental procedures requiring moderate sedation or GA in a patient with obstructive sleep apnea should be undertaken in a hospital with an anesthetic patient. What are the overview of psychiatric disorders and disorders of substance use in dental practice? Psychiatric disorders and disorders of substance use. The substance use can be alcohol, benzodiazepines, or opioids. May affect dental plans and outcomes. Patients with either type of disorder often face difficulties in accessing and adhering to the dental treatment, maintaining oral hygiene, and attending regular dental reviews. Be it psychiatric or the substance abuse, they have difficulty in accessing and adhering to the dental treatment. Even coming to the dentist is a problem for them, and also adhering to the instructions given by the dentist is also difficult for them to maintain oral hygiene, attending the regular dental reviews. Examples of barriers include stigma, social stigma will be there. Socioeconomic disadvantage can be there. Stigma means in terms of their appearance, in terms of their looks, or they don't want to show themselves to others. So different kinds of stigmas can be there. Socioeconomic disadvantage and fear of healthcare. Establishing a therapeutic relationship is important to support patients to engage with treatment. Psychotropic medications. So, what they meant by this establishing a therapeutic relationship, because they have to continuously be in monitor. So that is very important to support patients to engage with the treatment. They also should take medications to wean off these substance abuse and psychiatric disorders. So therapeutic relationship is very important. Psychotropic medications like antidepressants, antipsychotics, and stimulants, and other psychotropic substances like cocaine and amphetamines can have marked oral and dental adverse effects. Some medications like benzodiazepines, opioids, and gabapentinoids and other substances with sedatives like alcohol need to be considered if planning minimal sedation with anxiolysis in dental patient. For suppose if we are considering of giving a minimal sedation to a patient, we have to ask them about their alcohol usage, whether any drugs they are using, benzodiazepines or opioids or gabapentinoids, we have to ask them. Chronic excessive alcohol consumption can increase the risk of bleeding with some dental procedures. So that also we have to make sure what is their alcohol consumption levels, whether they are taking long-term alcohols. Then because their liver will be affected in alcoholics, so they obviously the bleeding risk will be more in these patients. A thorough medication and medical history should include the use of an indication for psychotropic medications, right? And other psychotropic substances. We have to ask them, including tobacco, smoked, vaped, or chewed, whatever form they might take. We have to take a thorough history of psychotropic medications or substances or tobaccos and alcohol and illicit drugs like cocaine or amphetamine, cannabis. We have to ask all the histories. What are all the medication, any hobbies, any habits, anything. We have to ask everything from the patients. Adverse oral and dental effects of psychotropic substances. Psychotropic medications such as antidepressants, antipsychotics, and psychostimulants can cause a range of adverse effects. Example like they may have dry mouth or bruxism, right? When compared with a karyogenic diet and lack of oral hygiene, dry mouth can result in dental caries, oropharyngeal candidiasis, and other oral infections as well. So, what they said, when combined with the karyogenic diet, for suppose if the patients are taking these medications, they'll already be having dry mouth and bruxism as side effects of these medications. So, and these medications, when the patients are having, when they are combined with a karyogenic diet, that means high sugary diet and a lack of oral hygiene, right? Just because they are using these drugs, that will not make them susceptible to caries, but they should have the karyogenic diet and lack of oral hygiene. Their oral hygiene maintenance is not good, and a dry mouth can result in dental caries and candidiasis and other infections. So consult patient's medical practitioner if a psychotropic medication is suspected to be causing a oral adverse effect. We have to consult the medical practitioner if at all it is affecting the oral health. Tobacco. Tobacco use, be it smoking or vaping, and the use of illicit drugs like cocaine, amphetamines, and cannabis also increase the risk of dry mouth and its consequences, right? Periodontal disease, dental caries, and bruxism. Tobacco usage can also cause this bruxism and dry mouth. Smoking tobacco is a major risk factor for periodontal disease, that is proven and written in evidence-based histories also. Tooth loss, impaired post-operative healing, including dry socket and oral cancer. So smoking tobacco is a risk factor for periodontal disease and tooth loss, impaired healing, and cancer. The risk of oral cancer conferred by tobacco use are increased by alcohol consumption. When the tobacco and alcohol together are combined, then the risk of oral cancer is more. They have added effect on each other. So, what are assessing and managing disorders of substance use in dental practice? In people with a disorder of substance use, excessive use of more than one substance is common. If they are using one substance, they'll be using other substances also. Consider the possibility of excessive use of opioid analgesic if the patient requests these, particularly if they exhibit a good level of knowledge about or a specific reference for a particular drug. Especially if they are referring for a particular type of drug, that means we have to consider the possibility of excessive usage of opioid analgesics. That means they are coming to us and asking, Doctor, I need some opioids. Those drugs really help me with the pain. I feel so relaxed with those drugs. If they exhibit this kind of knowledge, or if they're specifically requesting for these drugs, then we have to be very alert. Advice on assessing the extent of substance abuse is available in addiction guidelines. Checking real-time prescription monitoring systems can flag concerns regarding drugs of dependence dispensed to a patient. So real-time prescription monitoring system is also available. So whenever we are concerned whether the patient is drug abused or the dependent on the drug, but the list of monitored drugs differ from one state to another state and territory to another. Consult the patient medical practitioner if concerns about the substance abuse arise. Other sources of advice include the phone-based clinically advised services of the drug and alcohol services in each state and territory. So, first of all, we have to consult the patient medical practitioner. If concerns about substance abuse arise, if we at all we have a doubt whether there is any abuse, we have to consult a patient medical practitioner. Other sources of advice include phone-based clinical advisory services of drug and alcohol services in each state and territory. That is also there. If for contact details, reduction guidelines, a fact sheet on responding to inappropriate requests of drugs of dependency is available from the Royal Australian College of General Practitioners. Before prescribing drug of dependence, check real-time prescription monitoring services. Be familiar with regulations, legislation of each state on prescribing drug of dependence to a patient with substance dependence. Right, that is very important. We have to be legally familiarized about these topics. Patients with a history of excessive sedative use, like patients with a history of excessive sedative drug use, like analgesics, anxiolytics, some illicit drugs, excessive alcohol consumption, may risk oversedation or inadequate effects of benzodiazepines used for minimal sedation. They will not be effective. They'll become tolerant. Nitrous oxide is preferred agent for sedation in those cases. For advice on helping patients to cut down or stopping smoking or vaping, see advice for oral health professionals on Quit website. We can check that website. For medical management of nicotine dependence, overview of toe smoking and nicotine dependence in addiction guidelines. Guidance and resources for prescribers for therapeutic nicotine vaping devices and pharmacists supplying them are available at Therapeutic Goods Administration. So if you want any guidance about therapeutic nicotine vaping devices as an alternative, but it is equally damaging and deleterious, but that is some alternative. And pharmacists supplying them are available in TGA website. So coming to next topic, that is viral hepatitis and dental considerations. For medical management of viral hepatitis, every topic has separate management for medical management advice. The most relevant hepatitis virus to dental practice are Hep B and C, which are blood-borne viruses causing chronic liver disease and cirrhosis. They can cause chronic liver disease and cirrhosis. For advice on infection control measures, we will read that topic separately. That is a huge book again, 90 pages book. We have to read that separately. Most hepatitis C infections can now be cured by antiviral therapy. Patients with chronic or untreated Hep C has a higher incidence of oral lichen planus. So we have to keep all these things in mind. Lichen planus, dental caries, periodontal disease. And periodontal health is markedly poorer and salivary flow is reduced in patients with hepatitis C. Whether there is direct viral effect or due to the other cause is unknown. But they have periodontal health is very poor and salivary flow is reduced in patients with hepatitis C. Whether this poor periodontal health and salivary flow reduction is direct effect of virus or due to the other causes is not known, but generally these people have these conditions. Preventive dental care and management is particularly important for patients with Hep C because the outcomes of major restorative treatment may be poor. That is why we have to do preventive care and management. Before proceeding with the invasive procedure, we know again, we studied earlier in the 2-3 classes back about the invasiveness of procedure. In a patient with chronic viral hepatitis, consider the risk of profound immunocompromise. They are at risk of the chronic viral hepatitis patients are at risk of profound immunocompromise associated with end stage cirrhosis, liver cirrhosis, which increases the risk of infection. Because if they are profoundly immunocompromised, there is a chance of the infection in these patients. And bleeding risk should also be assessed for invasive procedure. Consult the patient's treating specialist or multidisciplinary team to determine the appropriate treatment plan. So these patients, chronic hepatitis C patients, can be at a profound immunocompromise because of the end-stage liver cirrhosis. That is why we have to take those profound immunocompromised condition into mind, and the risk of bleeding should be taken, and consult the patient's treating specialist or multidisciplinary team to determine an appropriate treatment plan. Avoid sedatives and other non-steroidal anti-inflammatory drugs, NSAIDs, in patients taking in patients with viral hepatitis. Just a second. Avoid sedatives and NSAIDs in patients with viral hepatitis because they can cause liver toxicity. As they are metabolized in the liver, they can cause liver toxicity. So avoid NSAIDs that we already know in patients with viral hepatitis. Paracetamol can be used at normal therapeutic doses. However, it is important to ensure that the maximum dose of paracetamol is not exceeded because the patients with viral hepatitis are at risk of increased liver damage at supratherapeutic doses only, not at the normal doses. So we have to avoid sedatives and NSH because they are metabolized in the liver. We have to avoid these drugs in patients with viral hepatitis because they can cause liver toxicity. Already hepatitis is there, that means liver is inflamed. On top of that, these drugs will cause liver toxicity, liver cirrhosis, and dental considerations. Cirrhosis, also known as advanced chronic liver disease. Liver, liver cirrhosis is also known as advanced chronic liver disease. Is extensive liver scarring, fibrosis, and nodule formation. There will be scarring and nodule formation. It can be diagnosed using non-invasive blood test and imaging of the liver. Liver cirrhosis can be diagnosed with non-invasive blood test and imaging of the liver. There will be liver scarring, fibrosis, and nodule formation. Chronic liver disease arising from any cause can progress to liver disease. If the liver disease is chronic, it can progress from any cause, be it from any cause, it can progress to liver cirrhosis. Patients with liver cirrhosis are at risk of liver-related complications that is obvious, including HCC, hepatocellular carcinoma, and death. Right? Once the liver cirrhosis happens, they are at the higher risk of liver-related complications. Treatment of cause of liver cirrhosis is a medical priority. This may be significantly improve liver function and portal hypertension and reduce risk of developing HCC. So liver cirrhosis treatment is a medical priority. That should be priority. Examples of treatment include facilitating abstinence from alcohol. So what are they telling when they are telling treatment of the cause of liver cirrhosis? If the alcohol is the cause of liver cirrhosis, they should abstinence from the alcohol, antiviral treatment for Hep B or HC, weight loss for metabolic associated fatty liver disease. So if the cirrhosis be it from any cause, right? So metabolic associated fatty livers also can cause cirrhosis, and immunosuppressive treatment for autoimmune hepatitis. All these conditions can cause liver cirrhosis. Compensated liver cirrhosis is a stable phase of the disease with good long-term prognosis if the cause of cirrhosis is treated. That is called as compensated. That means something is compensating the liver cirrhosis. By what? By treating it. It is a stable phase of liver disease. That means if at all you discontinue the habit or you started taking the medication, that can be reversed and a good long-term prognosis will be there. Decompensated liver cirrhosis is associated with high mortality and defined clinically by the presence of complications. Right? If it is decompensated, they'll have ascites, fluid accumulation. Ascites is the accumulation of fluid in the peritoneal cavity in the abdominal region. There so many people will have accumulation of the fluid in that region. Hepatic encephalopathy that has reached to the brain and variceal hemorrhage. Right? Encephalopathy includes what are the features? Change in cognition, personality, emotion, sleep disturbances, and disorientation. And gastroesophageal varices are dilated veins in the lining of esophagus and stomach, which are risk of rupture, causing gastrointestinal bleeding. So that can also happen in these patients. Or non-obstructive jaundice. So when the liver cirrhosis is decompensated liver cirrhosis, then there is a chance of mortality. Right? Patient may move between decompensated and compensated disease stage depending on the response to treatments, acute events, and disease progression. Liver failure refers to impairment of the synthetic or metabolic function of the liver. Chronic liver failure is end-stage cirrhosis. Once the cirrhosis progresses, liver failure happens. End stage of cirrhosis is chronic liver failure. Now, what are our dental considerations? Dentists play an important role in maintaining the oral health of patients with liver cirrhosis. For anybody, maintaining the oral health is very important because systemic disease can have impact on oral health. In early stage of liver cirrhosis, most dental treatments can be completed safely. If they are in early stages, they can be completed safely. Establishing good oral health will help prevent the need for more invasive procedures should liver cirrhosis progress. So, if the initial stages, if we can maintain a good oral health, it will prevent the more invasive procedures. Complications of cirrhosis that affect the dental care include altered bleeding and clotting tendencies. Because in the liver, clotting and bleeding factors will be produced, there will be altered tendencies, altered drug metabolism and excretion by liver. In some patients, excretion by kidney is also impaired with the liver cirrhosis because they are all related closely placed structures. In some places, kidney is also impaired because all the load falls on the kidney at that time. A risk of hepatocellular cancer and risk of progression to liver failure. Once liver cirrhosis happens, HCC can happen or liver failure can occur. With complications such as if the liver failure happens, then there will be hepatic encephalopathy. The patient will be having effect on the brain, profound immunocompromise. And in some patients, a need for assessment of dental fitness for liver transplant is needed. So we have to keep all these things in mind. Although most dental procedures can be completed safely for patients with liver cirrhosis, evaluating the risk of bleeding and clotting is complex. Traditional markers of coagulation. What are the traditional markers of coagulation? How well the blood is coagulated by INR, prothrombin time, do not accurately predict bleeding in patients with cirrhosis, and patients may have increased risk of thrombosis despite an elevated INR and PT. For invasive dental procedures that are likely to cause prolonged bleeding or for patients with active bleeding, discuss the proposed dental procedure with the patient's medical specialist. If we are doing an invasive procedures which can cause prolonged bleeding or the patients with active bleeding, if the patients are currently having more bleeding or they can likely cause prolonged bleeding, discuss the proposed dental procedure, right, with the patient's medical specialist. In addition to the use of local hemostatic measures, correction of thrombocytopenia may be required. Assessment is required on case-by-case basis. So bleeding risk is unpredictable. Consider referring to hospital-based dental specialist. We should take Here, what are we telling? You should discuss the proposed dental procedure with medical specialists. But since bleeding is unpredictable in these patients, consider referring to a hospital-based dental specialist for invasive dental procedures. If the patient with cirrhosis undergo routine dental procedures that are unlikely to cause prolonged bleeding, right? Correction of laboratory markers of coagulation with blood products is generally not recommended. If the procedure is not going to cause is unlikely to cause prolonged bleeding, then we should not use the blood products to change the laboratory markers. Metabolism and clearance of drugs by liver and sometimes kidney is impaired in patients with liver cirrhosis. Hepatorenal syndrome is functional kidney failure in patients with advanced liver cirrhosis and can be precipitated by infection and nephrotoxic drugs. Even the kidney started to fail. That is called as hepatorenal syndrome. Is a functional kidney failure in patients with advanced cirrhosis. Dentists should ensure that dental infections are managed efficiently to minimize the impact of infection or kidney function. Prescribing of any drugs for a patient with cirrhosis should be guided by a discussion with the patient medical team. We cannot prescribe any drug in these patients. It should be suggested by the medical team, general practitioner or liver specialist. Most common local anesthetic agents are at least partially metabolized by liver. Articaine is partially metabolized in plasma, right? But as well as in liver, articaine is metabolized in both liver and plasma, but most of the local anesthetic drugs are metabolized by the liver, at least partially metabolized. But evidence is lacking to demonstrate a lower risk of toxicity than other local anesthetics in patients with liver disorders. Because articaine is also partially metabolized in the liver and the plasma, earlier it was thought that articaine can be used in patients with liver cirrhosis. But now what they are telling is given the evidence is low, but evidence is lacking to demonstrate a lower risk of toxicity than other local anesthetics in patients with liver disorders. Given the low volume and doses of local anesthetics used in dentistry, dose reduction for local anesthetics are usually not required. So because we are giving already lower doses, dose reduction is not required. HCC is a common complication of cirrhosis. Patients with HCC are often under multidisciplinary management of a specialized unit. Therapy may include drug therapy, oral multikinase inhibitors, immunotherapy, anti-angiogenic therapy, or non-surgical therapies like abrasion, transarterial chemoembolization, transarterial radioembolization. So many treatments are there. The anti-angiogenic drug bevacizumab is a risk factor for medication-related osteonecrosis. For advice on other considerations with patients, we have to see cancer and dental considerations. But in hepatic cancer patients, because we can use medical practitioners can use anti-angiogenic drugs. It is a risk of bronch, and they can be using multiple therapies like multikinase inhibitors, immunotherapy, and surgical resection and liver transplantation. So many surgical and non-surgical therapies will be there. So we have to be very careful when treating these patients. Patients with cirrhosis may present with neuropsychiatric symptoms and signs associated with encephalopathy. Features of hepatic encephalopathy include changes in cognition, personality, emotion, sleep disturbance, and disorientation. Patients with signs of encephalopathy should be assessed for their capacity to consent. So once the brain is getting affected, their cognitive function can get affected, right? So we have to assess the capacity of how they can give consent, right? End-stage cirrhosis is cause of profound immunocompromise. Before an invasive dental procedure, discuss the patient's immune status with their medical specialist for advice on whether surgical antibiotic prophylaxis is required or not. Patients requiring liver transplant should have a pre-transplant dental assessment. Some transplant teams have a dedicated hospital dental team, but the dental assessment should include a comprehensive examination and x-rays. Whatever treatments are necessary should be completed prior to the transplantation. Identify sources of infection and teeth with a poor prognosis that may pose a risk of infection during the transplant period. The pre-transplant assessment is an opportunity to establish oral hygiene regimen. That is when we have to establish oral hygiene regimen and demonstrate a full recall program to suit the patient's individual needs. And the plan should recognize the impact of long-term immunosuppression and polypharmacy as a risk of caries, periodontal disease, and malignancy. Some patients may need prophylaxis against post-transplant osteoporosis. They can have osteoporosis, like because corticosteroids and other factors also will be there, which can cause osteoporosis. So, with drugs that increase the risk of medication-related bronch. So, in those patients who are at risk of osteoporosis, they might be giving certain medications, right? Bone anti-resorptive drugs or denosumab or rovacizumab. These kind of drugs can increase the risk of bronch. Ask the treating team to clarify whether and when such drugs are likely to be started, and this into account in treatment planning. So we should do all these things before a liver transplant is done. Once all the relevant dental treatment is completed, the dentist should communicate their assessment of patient's dental fitness for transplant in writing to the transplant team. Okay, guys. We'll continue with this in the next class and we'll complete this chapter. Thank you so much for listening to me. Bye bye.